Good evening, everyone. On behalf of Pentavision Ophthalmology Management, Ophthalmic Professional, and Care Credit, I would like to thank you for attending part 2 of our 4-part webinar series entitled Vision Correction for the Ages, a roadmap for successful patient journeys, creating memorable experiences. In part 1, we covered millennials and LASIK. In part 2 tonight, we will discuss dry eye disease and its effect on patients of all ages. We are grateful to our presenters this evening for creating this amazing presentation and sharing insights into their patient and practice management protocols and best practices. Dr. Elizabeth Yu is a partner at Virginia Eye Consultants in Norfolk, Virginia, specializing in both cornea and cataract surgery, which includes advanced treatment options for keratoconus, the diagnosis and treatment of dry eye disease, surgical management of astigmatism, laser cataract surgery, and complex-based lens surgery. She serves as an assistant professor of ophthalmology at Eastern Virginia Medical School, has authored several industry journal publications and book chapters, and is the co-chief medical editor for Millennial Eye. Patty Barkey, our second speaker, is the CEO and administrator of Bowden Eyes and Associates in Jacksonville, Florida, and the director of Dry Eye University, a program dedicated to educating industry professionals about the ocular surface and dry eye disease, and how to stop and how to develop a standard of care, train staff, educate patients, and create treatment plans for the disease process. Thank you again for attending this evening's program, and we hope you'll join us for parts 3 and 4, which will focus on the presbyopia and cataracts. I will now hand this over to Dr. Yu and Patty Barkey.
Thank you so much, Julie, and thank you everyone who's joining us tonight. I think it speaks to the fact that really dry eye has become quite a hot topic for a number of reasons, and I'm joined tonight with the Patty Barkey, who I've learned so much from the perspective of how to run an effective ophthalmology practice, and what she's done to take dry eye education to the next level with Dry Eye University is nothing short of phenomenal. We're going to move forward, and we're going to just basically be looking at, the history, the background, why the actual need exists, and how can we, in whatever setup of a practice that we have, and it can be from a solo practice, to one that is a multi-specialty group, but dry eye disease is very, very prevalent. In the different eye studies, as you can see here, the prevalence may range all the way upwards of half of a population that is being examined when you consider different signs and symptomatology. More specifically and more focused, if you look at 2015 Gallup study, approximately 30 million Americans are affected with symptoms that are consistent with dry eye disease, and this number is only growing. In the next decade or so, it looks like this will probably experience, almost a 10% growth. So thinking about 33.7 million people in the next 8 years who will have dry eye disease to some level of severity. And if we take a step back, of the 31 million people who we presently have in the U.S. with dry eye, there are only about 1 million prescriptions that are actually being written for, maybe 1.5 million prescriptions for dry eye medications. And what that signifies is dry eye disease, it's not necessarily what's driving people into our offices. In fact, a majority of the patients who are being seen for comprehensive eye examinations, over 80% of them are going to optometrists for their comprehensive exams, but they're going for glasses. They're not necessarily going because they have a disease state that is driving them into the doctor's chair. So, and it may also be in part to the lack of understanding amongst the general population of what the disease actually is. And now with all the various diagnostics, and we know the therapeutics, there's a huge difference in how we can positively impact our patients' lives in a way such that it is no longer the quote-unquote low back pain of ophthalmology or the headache of ophthalmology. So how common is this disease process? When you're looking at other comorbidities, I know it's a little bit cut off in the slide, but column 1 is allergies. About a quarter of our patients with allergies have concomitant dry eye disease for various reasons. The actual treatment of allergies is at baseline going to be antihistamines. 4 days of loratadine use, which is brand name Claritin, can decrease aqueous production up to 30%. And that's just in 4 days. And this is a selective antihistamine. So imagine what chronic Zyrtec or Benadryl can do, and that in itself is going to make dry eye disease worse. So ocular surface disease as a big umbrella really does encompass other components, including allergies. If you look at contact lens use, upwards of a half of the patients are experiencing some level of dry eye disease. Diabetes, yet again, probably about a half of patients, simply because this also leads to neurotrophic disease, and these patients are oftentimes more sick. The medications for their comorbidities of high blood pressure may in fact be exacerbating it, and it goes without saying that such a large population of our glaucoma patients have associated dry eye disease simply because the topical treatments can be so toxic. And a big basis of all surgical practices within ophthalmology is cataract surgery. And what we are seeing, and so thankful to Bill Trattler and others who have published this year, the acronym being the PHACO study. But, I was at first a little surprised by the results here, but and Patty, I'll ask you that question. I mean, when you talk to the surgeons within the practice at Bowden Eye, I mean, is it true? Do you think upwards of 80% of the patients are actually coming in with at least moderate dry eye, staining of the corneal surface, and how are you diagnosing your cataract surgery patients within Bowden Eye?
So I think this is one of the areas that's really, really interesting for all eye care practices is that, we have about 70 to 80% of patients walking through the door. So you have a captive audience walking through your door with complaints. And that other 20%, the issue is that there's a lot of asymptomatic patients out there too if we just kind of take temperatures and find those fevers going on with those particular patients. But for us, something as simple as the speed form, where you can elicit symptoms from the patient, or the patient that tells you, I'm constantly using eye drops to try to help my fluctuating vision. Fluctuating vision is never really just a cataract. That's the ocular surface involved at that point, right? So on all of our, especially anterior segment surgery and refractive surgery, cataract surgery, we tell those patients ahead of time that we're going to address the ocular surface. We're going to take a deep look at how we can help control and enable them to have better outcomes at the end of their surgical procedures. So this is all too true in our particular practice.
Absolutely, and I would agree there. And really the patients that are coming in, especially for our practices where we have a big collaborative or referral-based practice, we all have to be mindful that it is really the patient at the core of it, right? And when we look at it and think of it that way, if there's a disconnect between what the primary doctor, the referring doctor, who in our practice will oftentimes be the optometrist who refers that patient to us, if they're not hearing the words dry eye first from them, and in fact it's coming from me as a surgeon who's saying that I have to delay surgery because there is dry eye, I do need to fine-tune the surface, that alone can sometimes break down communication, create walls of distrust because, hey, well, how come I've never heard that before? No one's ever mentioned that to me before. Why didn't Dr. Kanji mention that to me before I came to you? Why are we delaying surgery? And so a lot of these patients, we're not truly giving them a diagnosis. And this may be because while there are certain good diagnostics, like, for example, the DEWS panel that demonstrate if you have staining, you're already a moderate dry eye patient. But we don't have something that is so objective and so standardized when it comes to symptoms either. either. So if it looks like they've got, just the fluctuating vision and just mild conjunctival staining, they may not be mentioning it to the actual patient themselves, but we have to come up with better speak and make sure that we're preparing our patients who are walking in the door. And fortunately, we have ways of doing this, and the same goes for screening of refractive patients. One study showed that upwards of 16% of the patients exhibit signs of dry eye disease. I think that this is an underwhelming number. I feel like the reason that most of the patients who actually end up in my chair, it's because of contact lens intolerance. That's about 3/4 of the patients. They're no longer able to wear them for the 16 hours a day, or it's contact lens abuse that led to problems and pathology, whether it be a small infection or otherwise, that scared them into wanting to come get LASIK. But I don't think that it's less than 20%. So I think this is a much smaller number than what truly exists. And this may be because it is a little bit of an older study, and we know now that while these patients may not actually have staining because they're younger, they're able to compensate and make enough tears to actually take care of the surface. These are the ones that are coming in, and I see this healthy surface. I do a tear osmolarity, and that was really a true aha moment for me, that their tear osmolarity is elevated at like 335 and 345. These are numbers that are already flipping them into that moderate to severe categories of dry eye. So it just tells you the dichotomy that can exist between our younger dry eye patients and, Patty, as you mentioned, our older dry eye patients who don't feel anything at all. But in fact, they're just talking about their vision fluctuation, and just like you mentioned, they have no idea that the blurred vision, that the baseline blur maybe is exactly the cataract, but the vision that goes up and down throughout the day or worsens with any prolonged activity, or you need to blink it in, that is actually ocular surface, and that will not go away after surgery. So we have to help prepare their surface and reset expectations in the management of our patients. So there's all sorts of different reasons that dry eye can happen. It's multifactorial, as we understand. And yes, the classic one is the female, older, peri and postmenopausal, and obviously those with autoimmune diseases. But just like the title of tonight's webinar, it's, yes, there's boomers on one end, but it's millennials on the other end. I don't know about you, Patty. I mean, have you seen a shift in and have a greater focus on younger patients coming in with dry eye concerns and issues?
Yes, we've had, we recently had a patient that was a young attorney who basically it got so bad for her that she actually quit practicing law to start staying home and focus on her conditions. We see these people, when we do that speed, and then we also follow with osmolarity, because the speed will drive us to osmolarity and inflammatory to check for inflammation. And yes, a lot of these young patients, the contact lens patients, we have a high volume of them. And my docs will talk about how the volume of contact lens patients or contact lens growth in the industry has been stagnant. It just kind of stays the same. Well, every year they're dropping out, right? You put new ones in, but we're having them drop out. And doctors are spending so much time trying to refit this patient in a different contact lens when it's not the contact lens, it's actually the ocular surface. So you get these younger patients who are frustrated that they can no longer wear their contact lenses. They're spending so much more time on their cell phones and their computers, and they've got meibomian gland disease and blepharitis going on. So, yes, I mean, it seems that they're getting younger and younger.
Yeah, and it's really surprising. And, Priya Gupta showed at last year's ASCRS a series of patients who are adolescents. They're in their teenage years or younger, and they've already got moderate meibomian gland dropout. It is shocking, and it's actually a little bit scary to see. And, I think to myself, but why am I that surprised? My son, who is in first grade, has 2 hours of computer class 3 days a week. So he's already on that device where there's going to be a lower blink rate. So you have that lower blink rate, and we know that an effective full blink is absolutely necessary to cause the lids to express the meibomian gland so that it lets the meibum out. So if that meibum's not going to come out, that is absolutely going to build up, and then it causes dropout, and that exacerbates disease. And so if that's already happening now, 2 hours a day, and that's on top of the iPad that he watches in the evening, it is surprising, but it shouldn't be surprising. And what's going to happen if we do not identify these people and treat these people at an earlier age, I'm scared to see what it's going to look like in about 30 years when we have more intractable dry eye disease that's going to be much more rampant. So I do agree that, we have to really be cognizant of capturing those, and a speed questionnaire, just like you mentioned, that symptom questionnaire sometimes is absolutely the first thing. And so, if you don't mind, Patty, I want to pick your brain because you and I, we've already mentioned Dry Eye University. Can you tell us a little bit about Bowden Eye, and then what made you decide? I mean, was it out of necessity, or was it because so many people came to you and were coming down just to see how you guys, championed a dry eye practice? How did you start with implementation, and how did the Dry Eye University come out of this?
We had early on when Tier Science got a FDA approval for LipiFlow and for the LipiView system, we embraced that early on because we had constantly been trying to find ways to help our ocular surface disease or dry eye disease patients. And we became what was called a center of excellence, where people would come to learn more about dry eye and, really how to implement that LipiFlow system into their practice. But I became the host of those particular visitors, and I would spend time with them in the beginning to find out, what are you doing for dry eye now? How does it fit into your practice? So we could kind of talk them through our process. And I always began my session with, what are you doing now? And I would ask certain questions. And I think I was just always amazed at the lack of knowledge about even the things that were available on the market for now. For instance, whether it was Restasis, how is Restasis used within your practice? And so many practices didn't understand the value of that particular drug or how it worked, right? So
sure.
And we were looking at LipiFlow, how we could implement that, but at the end of the day, LipiFlow wasn't going to solve all the problems because of the multifactorial effect. So I was constantly emphasizing, this will be great, but this is great for this particular segment of patients, being the meibomian gland disease patients, right? So,
sure.
And, you can only teach a visiting practice so much within a 3 to 4 hour period of time in your practice. So I went to several vendors and I asked about Dry Eye University, would they be interested in it? I thought it would be great. I remembered my experiences with AMO University and refractive surgery. And everyone thought it would be great, but, the industry as a whole really wanted to kind of focus on their own particular territory. So that was when I said, you know what, we're going to do this ourselves, and we're going to make it a well-rounded program that addresses all the multifactorial effects, so people have a basic understanding of dry eye disease as a whole and everything that's influenced, and then the tools and the building blocks that are available to use for those patients and how they apply. So that's how Dry Eye University came about. We've had, we just did our 8th program. We've had all over the world. We've had every state in the nation represented there, and we're very proud of the program, and we get great feedback from it. But within it, we start with, where do you start if you're thinking about really implementing? And by the way, practices that just have osmolarity or they just have plugs, you're really not treating dry eye disease. You got to understand the multifactorial effect to be a true dry eye practice. And, where do you start? You can be the full-service practice that, like Bowden Eye or Virginia, where Dr. Yu is, your particular practice, you're comprehensive. You're offering diagnostics to fully diagnose those conditions. You're offering treatments that are available. You're offering products or procedures. And then there's the shared care practice that maybe they can't afford all the bells and whistles or the top-level equipment for treatments, but they can do the diagnostics. They can do certain lower-level treatments, such as BlephEx, which is an amazing revenue generator, creates happier patients, more comfortable patients, and it's a step that can be implemented, and then products available for the patients. Or better yet, maybe your practice doesn't want to get fully involved, but you just need to recognize them and get them to somebody that's going to take care of them, because just like we talked about earlier, it's not going to go away. This is going to grow, and it's going to grow rapidly if we don't get it under control for these particular patients.
Gotcha. So for Bowden Eye, tell me about your referral base and how have you worked with them so you can do exactly that, associate and collaborate?
So I've worked with a couple of practices, and what I've found works really, really well if they understand the dry eye conditions and we help them with the referral component of it, of what's available, then there's certain things built into their practice. Like every practice could have osmolarity, for instance. Every practice can have inflammadry to measure inflammation based on those speed scores and those symptoms. And then they can, express the glands, even if it's just a Q-tip, to see, is it oil coming out or is it sludge coming out? Because if we've got sludge, we've got a problem. And we need to have a treatment, or else that sludge is going to become a blocked gland for those patients, and then those glands are going to atrophy. So we can help customize the practice to build, whatever they want to be. Maybe they just want to offer products. So the products that we offer in our practice, they would want to offer in their practice. So if they sent a consult over to us, when the consult went back to them with the recommended treatment and we've done our part, the patient can remain in their practice and continue to purchase those products and stay on that treatment plan that's available, so that those patients can embrace, we always tell the patient, I'm sure you do too, that we're in it together. We can't cure this. We can only try to get you more comfortable and try to prevent progression, much like glaucoma, right? We're trying to prevent that progression. So we try to work with them to help them be able to do their part. And I don't know about you, but, with your cataracts, don't you just love it when you get a cataract from one of your optometrists? They've already started the treatment plans. The ocular surface is now under control. The patient's engaged, and now you can just proceed with surgery.
No, absolutely, and I think it's actually imperative that we do have that level of collaboration, because when we don't have that and we're not looking at it from a primary to a secondary or tertiary center, then that breakdown does lead to confusion. It can lead to dissatisfaction with the patient care, because the patient feels like, there's discourse in the diagnoses and whatnot. And, so with Virginia Eye Consultants, you're absolutely right. I mean, we are a multi-specialty practice. We have the way we've learned, let me back up, and say, yes, we have really employed the different components of a dry eye practice between John Shepard and myself, for years at this point. We have a champion with an in-house optometrist, Walt Whitley, who does a fantastic job. And we sent Alexia, one of our refractive and dry eye counselors, to Dry Eye University just recently, because there's always room to learn. But the point being that the next two slides are some of the absolute most important part if you're thinking of going into and kind of embracing adding more dry eye treatments and technologies into your practice. There are 17 of us, and of the 17 of us in the practice, there's 4 ODs, and there's two main cataract surgeons, Dr. Scoper and myself. Between the two of us, we do a little over 3,500 and then about 4,500 within the practice annually. So the volume of cataract surgery is higher, and we have that need to make sure, in order to serve our 75% optometric referral base properly, so when these patients end up finishing their postoperative care, going back to their ODs, that they are demonstrating a higher level of satisfaction, which is both objective outcomes as well as their own subjective outcomes with their quality of vision. The core of that is managing that third refractive surface, which truly is the tear foam and the surface that's in front of the eyes. And so having that champion or that project manager, I believe, it needs to be one of the absolute cornerstones. And some of the other pearls that I would mention is that there should be, no matter what, a standardized process through this, whether that education piece looks like it's something that you do at a one-on-one level with your referring doctors, or if it's through CE programs, or you are getting out to, the senior living centers, and we've done it all, but having that foundation where you are determined to set a level of education, which is partly also marketing, but being able to get the word out that you can do and offer something that maybe not every practice can offer. And then from the perspective of sharing and caring, a collaborative care of our patients, we want our primary doctors to go ahead and prescribe the prescription anti-inflammatories before they see us, giving them a good 4 to 6 weeks of treatment before they end up in my chair for their diagnostic images. We want them to start punctal occlusion, so we've even had punctal plug wet labs. And then obviously teaching your staff on how to read and engage the patients before they see us. Are there what other pearls can you advise Patty with regards to that process in your practice?
Well, I think another point, too, to be made is we need our referral sources educated, and we need them engaged, and we need them part of the process, because we don't want to present something that's never been presented because of the patient's perspective. But we also have to be careful with our patients on what is perceived as almost a bait and switch, too. If a patient's coming to for a cataract consult from an outside source, and suddenly the visit turns into a dry eye consult, which, by the way, a high percentage of the care is cash basis in the dry eye arena, it can look like a bait and switch to the patient, and they can get so confused and caught up that they leave without scheduling anything. So we try real hard. First off, you don't have to market for any of these patients. They're going to come in your door. You just got to find them by, evaluating them the right way. But when working with the referral sources, we do try to engage our specific sources with, this is what we do, this is what we have to offer, this is what's going to take place in the standard evaluation for our patients. So there is no surprise. We reach out to those patients ahead of time. We offer them, maybe it's a cataract packet that's mailed out, and it includes dry eye information for them so they're not surprised. We encourage them to go to our site. Checked Up has a great piece. Where you can email them something where they can get the information ahead of time to watch those videos. There's so many different sources, but from Dry Eye University for the docs and the staff, the education for the patient base is so large. You have to educate them, or else the providers become so bogged down, they just can't teach every patient about this new disease that they're now being diagnosed with. So counselors are one of my biggest, I'm a big advocate for them. And any practice can take your contact lens technician that's teaching how to put contacts in, teach them how to educate patients, your refractive counselor, your cataract counselor, any surgical counselor can become a dry eye counselor as well. So that helps the process.
And that dry eye counselor, do they see the patients before the patient sees the clinician, which is not for like our cataract patients, they meet the counselor and learn about cataracts in the process before they meet me, the surgeon. For our dry eye side, because most of these patients, as we have already discussed, are not coming in with that diagnosis necessarily, they end up meeting Alexia or another dry eye counselor after they've talked to me to go through the specifics of my recommendation. How is it done with Bowden Eye?
We actually try to do it ahead of time. So what we do is, if it's a cataract consult, the patient's going to see the cataract counselor who will also delve into the dry eye component as well. And what we do at the technician level, if the speed score is 1 or more, and we start with 1 because they're symptomatic, the technician will say, you have signs and symptoms of dry eye disease, so there's some diagnostics the physician would like for us to do prior to seeing you so they can help properly diagnose your condition. They will get those, and they say, we want you to, we're going to have you meet with our cataract counselor who's also going to educate you on some of the treatments available for dry eye disease, so that when the physician gets the patient, they aren't hearing about there's nutraceuticals available to help you, such as Hydra Eye, or they aren't hearing about a mask that's available, or they aren't hearing about LipiView, because we'll try to get both scatter and meibography and LipiView so we can look at the blink rate and the lipid layers prior to the physician even seeing the patient. It works wonderful for us. You'll get every now and then that patient that's like, no, I just want to see the doctor. And then we flip and do it in reverse, but most of the time it facilitates our physician making a recommendation for something that makes sense to the patient. Now you can hand the patient back off to the counselor for closure and scheduling.
I see. And do you have a specific physician champion, quote unquote, or an OD champion within the practice, or is this something that each of the doctors do?
I am so fortunate to have a group of champions. So I have, obviously Dr. Bowden is a big champion, and he's, the king of them. But Dr. Darbandi, Dr. Cronin, who's a brand new physician to our practice, has already attended Dry Eye University and embraced. Every one of my optometrists has the ability to order and schedule LipiFlow, to do osmolarity. They can control that whole patient with the exception of, obviously, if they need a surgical procedure, or if they need, we do meibomian gland probing in our practice as well. That goes to the physician. But they can handle, BlephEx. We must do 10 to 15 to sometimes 20 impromptu BlephExes during a clinic day throughout our locations and clinics. So everyone's engaged, everyone.
So I think, as this slide shows, having that SOP or that standard operating protocol from a clinical perspective as well as a financial protocol, which we'll go into a little bit later, it has to be just like a cataract process or protocol in that evaluation. We need everybody to be in tune. Now, it doesn't have to be everybody necessarily in the practice, but there has to be some level of engagement from the technicians who are going to be performing the procedures, who can understand and not necessarily translate, but at least describe what and why it is going on, and then having people who can educate, like specific counselors and doctors who actually enjoy and want to take care of these patients, because I'll tell you, there are surgeons, and there are surgeons within my practice. Cutters want to be cutters. They do not necessarily want to take care of dry eye. But I can say that I have so much respect for that, for my partner who says, you know what, I am not the person you want managing your dry eye disease. I will do a phenomenal job managing your cataract surgery, but he's going to introduce that patient to Dr. Whitley, who will manage and optimize their surface. And once they're ready, then they'll go back to the said surgeon in order for cataract surgery to occur. And that handoff, when they meet and get that recommendation from the surgeon, that's another way of doing it, and it works very, very well. And to make a dry eye center a comprehensive one, it does need to have some of these other components. And that would not necessarily include everything, but having diagnostics and offering procedures, if you can, within your practice, because there are so many procedures for the ocular surface that are both cash-based as well as insurance-based that can make a significant difference in the way patients feel, because truly, and Patty, I don't know if, I'd like to hear your thoughts on this, but what I've learned from experience and just what the last 5 years have shown me in this growth and discovery is that dry eye disease is not only managed by drops. In fact, it is not a disease that is cured by drops. It is drops, yes, plus intervention of some sort oftentimes. And why? Because meibomian gland disease and lid disease are such a big part of it, and those are mechanical issues.
Yes. Yeah, and we'll tell patients, we do a large number of LipiFlow procedures, for instance. But we tell patients the value of that particular procedure is only enhanced by the things we're going to provide for you that you can do at home to maintain that value of that treatment we just did. So,
right.
Yes, between masks, between products, True Tears hitting the market soon, and those of us who have gotten to try it, it's going to have a huge role. Nutraceuticals, all of those things go hand in hand. There isn't one particular magic bullet that's going to solve this problem for patients. And unfortunately, I think, the frustrated patients that get to us that have gone through multiple providers because no one's been a problem solver for them, that's one of the things that's frustrating for them because maybe they were just given, like you said, a prescription for drops. Well, that alone is not going to solve the problem if the patient has multiple things going on. We have to address and impact each of those conditions to make headway for the patient.
Right. And just like high blood pressure or diabetes, which is something that we can all relate to more on a more macroscopic level, monotherapy only really, I'd say, cures 10% of diabetics or controls 10% of diabetics and hypertensives. It's the same thing. For our ocular surface disease patients, if they are caught earlier in the disease process, before they're requiring artificial tears daily 4 times a day, if they're actually managed before that level, I do have patients who experience great success on just lifitegrast topically or just cyclosporin topically, but that's the minority. That's only maybe 10 to 15% of the population. By the time that most of these patients are coming in, there are other causes. And let me tell you, having greater tear production, having less inflammation, that is not going to overcome the fact that these patients have a poor diet and that they are staring at a computer 8 hours a day. It's a supply and demand. There's not enough supply to meet the demands that their eyes are requiring of them. So there's these diagnostics, and we'll go through just a few, and I'd like to hear exactly which ones you're doing. Procedures, the patient education component, which is also going to include that come to Jesus talk sometimes, and then, going into depth about retail and what to offer, and that how these can all ultimately lead to that greater, it's like a whole nother line of profit growth that is growing for you, especially if you're thinking about that patient who's getting that monthly nutraceutical and they're getting it from your practice. And there are several that are specifically sold within the eye care professionals' practice. And so these patients, and there are a lot of them who experience a very good amount of relief just from being on the nutraceutical. And they'll tell me, when I stop my Omega, and specifically for me it's Hydra Eye, that we sell, if I stop my Hydra Eye for more than 2 weeks, I can tell that I'm less comfortable by 5 p.m. I can't get through my work day. I mean, it does show you that having it with the improvement to the tear film through a better meibomian gland and being an anti-inflammatory is helpful, and so it just further supports that. So is that patient conversation, Patty, in your practice? I mean, did Dr. Bowden teach the other doctors how to have that conversation?
Yes, we have monthly provider meetings, so we're always discussing, not necessarily scripting because you have to read the patient and talk to the patient, but there's many come to Jesus meetings, and as we've gone through this for about 5 years as well, we've tweaked things. We've read the patient, which patients are receptive to this discussion. How does the discussion go? It's a constant process until you get it down, just like it is for fitting contacts or anything else. It becomes standard operating procedure or standard of care, how we're going to address these particular patients. So I would say each of mine have their own personalities involved with their patients with dry eye, but the common thread is the same. So they agree on the standard of when we're going to do BlephX, when we're going to do LipiFlow, when we're going to utilize the diagnostics. So if a patient ends up in your clinic or this other person's clinic, they're going to see that common thread. I always tell my staff, if you worked at McDonald's, you have to know what's on a cheeseburger. And isn't it amazing that you can go to any McDonald's around the nation and the cheeseburger is exactly the same, right? So
that's right.
Patients expect that sort of branding, if you would, or comfort when they go from provider to provider. So,
right.
Yes.
I agree with you, and I think what has helped me be successful when I do have those conversation pieces, because it can be a little bit, these dry eye patients sometimes come in very guarded. They can come in frustrated. Other times they can come in suspicious because you're the one giving them the diagnosis, right?
So
for the I mean, there are three basic components that I always want to stress with these patients. I do liken it to other diseases that are chronic, because sometimes patients don't understand the difference between acute and chronic. They don't know. These are, to some degree, medical terminologies, but to say it is a disease that doesn't necessarily have a cure. Similar to high blood pressure and diabetes, they don't all have cures. Just because you lose weight doesn't mean that the diabetes goes away completely. We still have to maintain and keep it supported, and that may be over time with one or two therapies, but it is a chronic condition. And then I also go through with them, there are different reasons why you have your form of dry eye disease. You use a ceiling fan at night. You're on the computer 8 hours a day. And from what you're telling me, you're definitely not demonstrating taking the proper amount of hydration necessary. And you're also on a beta blocker for your high blood pressure, as well as you're over 55 years old. All of these things are contributing to your dry eye disease. So you have multiple reasons that have taken you to this point of dry eye disease. And where you are today, I know you feel worse little by little, as compared to 5 years ago. So when you demonstrate some of these things, that it shows them a few things. One, that there is a longness or this chronicity to it. It also demonstrates that because of the lack of true care, there is this progression to their symptoms, or the worsening in frequency as well as severity. And then the last part is there are multiple reasons for it. We'll never get rid of all the reasons for it. You're not going to become 20 years old tomorrow. We can't restore your hormones, but we will need a few different ways to get them to be stabilized, but it's unlikely they'll be cured per se. So moving on, so what kind of diagnostics, Patty, do you have within your practice that you incorporate into your standard operating protocol, so when they come in for that dry eye evaluation, pass the SPEED score?
SPEED, tear osmolarity, Inflammadry. Of course, we'll do Inflammadry on any first visits on dry eye patients, and then offer treatment and bring them back for a follow-up to get a negative. You'd be surprised how many are positive. Meibography, we always want to look at those glands. Also use the Korb Evaluator and express glands at the slit lamp eval. Topography, topography is not as much. It depends on the patient type. We have the HD analyzer, and the scatter testing is phenomenal to teach patients and educate the patients about their particular condition. So we utilize all of those every day, all day in our particular clinics.
I'm going to tell you, we are not as advanced in terms of the diagnostics. I mean, we certainly have, so our SOP for dry eye, every patient who is a positive symptom questionnaire is going to get a tear osmolarity. And I think part of that is because the tear osmolarity, it does have this objective numerical value to it, which going into the interpretation of that is not within the scope of tonight's talk, but it does provide at least some basis for the conversation. But it also, in our area, there has just been better reimbursement, especially over the last few years. I'm pretty certain Inflammadry has made big strides, but our big HMO provider, it was not on the insurance plan. It was only for one eye. How can you get just one eye of Inflammadry? So it was a little bit more difficult. So we've reserved Inflammadry for follow-up dry eye patients, but tear osmolarity and meibography we get on every single patient. I think the meibography has been the most enlightening diagnostic that we've been able to show patients, and there is no variability there, right? I mean, I could do it today, I can do it 5 times today and 5 times tomorrow. The glands are going to look the way they're going to look. So there is a significant reproducibility, and when you can demonstrate the truncation, the black areas because you're missing healthy glands, that speaks volumes to the patient in support of what you are trying to demonstrate is going on. So the HD analyzer we love, and after we went to your dry eye university, we're trying to figure out a protocol on how we can also do the scatter plots for all of our dry eye patients because it also does the tear breakup time, doesn't it? So to get the tear breakup time analysis through the scatter plot images, plus just the scatter image in itself where it shows you the OSI, the ocular scatter index, those are very powerful software pieces within the HD analyzer.
In the world of rainbows and butterflies, if you could do that on every single patient that came in, you would pull out so many patients to demonstrate to them their conditions. The problem is, we have to be careful with that because that takes time to perform that test on every particular patient. So you have to be careful there. And, one of the other points, too, is LipiView with the blink, looking at the number of complete blinks is huge because to be able to show patients metrics from osmolarity and LLT and inflammadry, those metrics and follow-up visits are so important because the patients will come in and ask, what's my score today on osmolarity? What's my, how am I doing with this? They start to embrace and engage in those particular metrics.
Sure. And so, just as important as those diagnostics are, like we mentioned, having that visual to demonstrate to the patient. And we have, like for myself, on my own sign-on page on my desktop, I have like a little folder of what quote-unquote healthy looks like as compared to theirs. Now, when you look at this lid, like in this on the left side of the slide, it's very obvious that having those little yellow crusts are not normal. I will show them something like this. I will show them the healthy meibomian gland image, which shows nice berries on the structure. It's long. It goes down to the fornix. There's no congestion. And then obviously what differs with their image, and their image may be the dropout. It may be severe congestion. It may be serpiginous changes, so it looks much more corkscrewy because it is obviously damaged. It's wishing that it could get expressed, but it is not getting expressed. And then occasionally, especially when I see a very impressive lid margin, I'll bring that to the slit lamp and I'll videotape exactly what is coming out of their glands as I'm compressing it to demonstrate that, just like you said, when it is really cheesy or very congested, they get that. They know that oil should not look of that consistency. Yes. And here, this is, again, this is just to demonstrate conjunctival chalasis, but to demonstrate that in such patients that when you actually have folds that are breaking up the tear film, that affects the surface and leads to the pitting. And here it's the green staining. So talk to me about I think you have a whole host of procedures, but if you can tell us, if there were a few, for someone who is starting out and wants to get into more of the procedural side, what would you say are like the home run ones that can be well incorporated with good uptake, Patty?
Without a doubt, LipiFlow, it is like the catalyst, a driver for your particular dry eye clinic. It is a treatment that patients can feel, they can get it, it makes a difference for them. And then BlephX, you can't go wrong. Anyone, any physician, I don't particularly encourage technicians to do BlephX, but when you see that patient with those lid debris that you just showed, that's a patient right there, impromptu. Your tech that's taking a pressure can say, we have a treatment we're offering in the office today, much like having your teeth cleaned. We know you brush your teeth, but you still go to a dentist and have your teeth cleaned. This is preventative, and we can help you. And we have 3 levels of BlephX we offer in our clinic. So it's a huge financial reward. Care Credit comes into play with that because it's real easy for them to do it, impulsively right there at the moment. And most of those patients will want to and usually come back for 3 to 4 treatments a year, and they just feel the difference. So those are, if I had to pick 2 for anyone, it would be LipiFlow and BlephX.
Interesting. So tell me about this 3-tiered BlephX that you offer. We have BlephX. I'm very open to say that I do not do BluffX very often, it actually just slips my mind because I'll just mechanically debride them, myself. But you're right. I mean, doing it with swabs, am not nearly as efficient as this, rotary device that can so gently exfoliate and probably get deeper in treatment than what they're getting with me.
And it feels good. So we have, we'll do just a standard BluffX to clean and get rid of the debris, or we will do what's called a BluffX Express, where we clean and we'll also do some expression for that particular patient. And some those patients are great to have that done in between their LipiFlow treatments. It'll help facilitate that lasting longer. And then also, so the third one is a BluffX Plus, we call it, and that's when we'll go ahead and do a treatment for Demodex while in the office. So we'll do a Claridex treatment, do the BluffX, and then send them home with Claridex to help eliminate that Demodex that they have. And we'll pull a lash and look under a microscope, and you can see, the live Demodex on those particular patients, usually the ones with collarettes. So we have those 3 levels, and of course 3 different levels of pricing as well for those patients.
Gotcha. So, and then now moving on towards, retail therapy options, I would say there's no way that we could just offer procedures and not offer some level of retail products to help augment and support the therapeutic treatments. And I think nutraceuticals and the omegas are such a huge part of it, as well as the different lid hygiene offerings and the premium artificial tears. I mean, is there anything above and beyond what you see on this list, Patty? I know humidifiers are effective, and we do sell portable humidifiers, but what else does your retail therapy look like?
Ours almost looks like yours. IECO's moisture chamber glasses are always great for some of the people with lid closure issues, so we'll keep those available because they're just like a moisture goggle that will contain the moisture, especially at night. So Hydri, of course, is our favorite nutraceutical, and we have thousands of patients on that product. But ours pretty much looks like yours. We have Fire and Ice has kind of faded out for us. Brooder, the Derm, which is also an IECO, and then iGene has one that's really nice. That's kind of an upper end one, but people like that one as well. But we have most of what,
and that was what I was going to, there actually is a question from the audience. Dr. John Redman was wondering, so what about IPL as opposed to LipiFlow? Do you offer IPL?
Yes, we do. LipiFlow is offered in conjunction. It depends on the patient type. And I'm sure in your clinic you're using it too, but patients with rosacea and inflammation, those patients are usually having LipiFlow and IPL as well. And we do expression during IPL, but to really evacuate those glands well, you need the LipiFlow to do that. But we do a lot of IPL as well for our patients.
Sure, and I don't do IPL. We don't have it, but I'll tell you, having spoken to people who do use it and use both, there definitely is a place for both. I think both, they're in that Venn diagram where you can help posterior margin disease. IPL is beautiful. When there is that telangiectasis, it is very nice to be able to decrease the telangiectasis, so you're decreasing the source of where the inflammation is coming from. So where those patients who have that primary posterior lid inflammatory process, that true blepharitis, where it is red and inflamed from that rosacea, or from even being on chronic prostaglandins and the damage that it causes, to be able to shut down some of those lid vessels with IPL, which is done, monthly or every 2 months over 3 treatments. It's also sometimes a little more palatable as a financial perspective because it's not a one-shot type of procedure, but it's done over time. So, I am going to now go to, speaking of the financial component, Patty, if you can I was shocked at this revenue sheet that you demonstrated and going into care credit. If you can kind of go into this information, that would be great.
Like we mentioned earlier, a lot of the revenue that's driven in dry eye And when we look at adding any particular profit center to a practice, obviously it has to be profitable. We want to take great care of the patients, but we want to get paid for what we're doing because there's chair time involved and product involved. So by implementing your standard of care, this is just an example of how a standard of care can go and what it can drive in your practice when you get your volume up to taking care of these people. Care credit comes because, if you look at, a lot of these charges, the ones with the gray arrows are ones that, predominantly most of the time insurance is covering those with the exception of copays or deductibles. But when you look at the orange arrow, those particular ones are out of pocket. So care credit is huge. We always offer care credit first. This is what you need. This is the treatment plan the doctors prescribe for you. And for as low as whatever per month, we can go ahead and get this going. The patients are going to be ongoing coming in to get their products. This is not a one-time, you need the one bottle of Hydra-Eye and you're going to be good. We got to stay on Hydra-Eye. We got to stay, for instance, here when it comes out. You got to have that monthly supply of tips to be able to make True Tier valuable to your system. So care credit is just, it's an amazing because it is not just a financing company. It's a credit card. They've got available credit. They can come in and use their card at any point. And like on your website, I'm sure they can use it to get their products from your website. So revenue is just tremendous. So anybody that's dismissing dry eye by saying, I don't want it to mess up my cataract or my surgical volume, okay, it's not going to mess up your volume. You can still have your volume. You're just going to have greater outcomes, and your revenue stream is going to be even greater. And guess what? You're going to have happier patients in the process. The tools for engagement, this is awesome as well. Anybody that's a eye care provider that's using care credit, boy, the tools they make available to us, just like this webinar tonight, or social media things, they're constantly sending things that you can use in your practice.
And so who in your practice is that point person? So is it the doctor who discusses some of this financing, or are the counselors trained? How does that happen? It's always a difficult conversation. I can say personally as a physician, I don't actually ever talk price with my patients.
Oh, I don't want my doctors to ever talk price with the patients. I would prefer that the counselors do that. They're taught how to be diplomatic. They're taught how to, we're not rationing eye care. We're not judging these patients based on the purse they're carrying today or the shoes they're wearing, whether they should be allotted this particular care. Follow the standard of care, hand the patient, make your recommendations based on the patient's signs and symptoms, and then turn it over to the counselor to help capture and evaluate the patient for how they would like to pay. Patients with a lot of money still prefer to use credit. They want to keep their money in the bank. They have that option. So we start with the credit portion up front. We offer that to everyone, and if they say, no, I don't want to pay credit, I'll just use my cash, then that's fine. But we offer it to everyone across the board.
I think your slide that you showed of the revenue from April 2017, that one snapshot, and when you look at the profit center that you created from having a committed dry eye center of excellence, it shows you that while it does take a commitment on the front end, we certainly can, when one, create happier patients, but two, make it a profit center for the practice, because at the end of the day, whatever we're able to do, we have to be able to pay for the bills, right? And so, this is where these procedures and these offerings on top of the prescriptions that we're writing in conjunction can be, I think, provide a great synergy for our patients.
Yeah, it's amazing. When we first started, I called dry eye the beast because it could just keep growing. So it was in the practice, right? And you know what? They're commodity patients, because once you make them happy and you help them because no one else has seen fit to do so, they're your patient for life. They want to be a part of your practice.
Sure. So we are now coming to an end, and there is still that Q&A button if you have any last questions. Patty and I would be happy to answer any questions that come through, but I want to thank Pentavision and Ophthalmology Management as well as CareCredit for providing such a resourceful webinar for those practices and doctors who are interested in kind of embracing and enlarging, expanding dry eye services for their practice. So thank you so much tonight for joining us.
Yes, thank you so much. And it was an honor, Dr. Yu, to be able to do this presentation with you as well.
Okay. Thank you, Patty. Trust me, it's been wonderful. I'm very lucky. I don't get Patty time very often.